documentation. We've been doing it for a while. All pretty good at it, we like to think. But we're going to go over the really kind of everything, soup to nuts of documentation, what is required in a siren report. So the big thing is we have really 24 hours to get these reports done. Generally, we're pretty good at it, but sometimes not so much. The reality is relax on shift. Definitely have fun with it, but just know that you have 24 hours to get it done. You can absolutely relax on shift, mess around, but either you're going to be staying late at the end of your shift or you won't be able to have as much free time on shift. This is everything that we have to include in a PCR. Fortunately, Siren just makes all these boxes red for us, and they pull the data automatically. So we don't need to worry about knowing what all this criteria is. Just know that it's being gathered. But we'll start with the dispatch. The default is a 911 call. We do more than just 911 calls. That's the reality. So we should pick the most appropriate call type. So if a paramedic is going on medic intercept, it would be intercept. If we're doing a interfacility, so this is from BMH to another facility where you're getting a nurse's signature, that's an interfacility transport. But what about those patients you bring home? Medical transport, they're different things. It's not an interfacility transport, it's a medical transport. I feel like that's a common one that we probably do incorrectly a lot. If we're called outside of our coverage area, that'd be mutual aid, would be the most appropriate. Public assistance, so your lift assists, your dispatch reason would be public assistance or public assist. And then if you're called to a fire scene for standby, it would not be a 911 response, it would be a standby. That's your dispatch reason, is to stand by at the scene of the fire. That's the most appropriate thing. And this way, Drew and Mark, they can actually track the data a little bit better as to what we're being dispatched for as opposed to what actually happened. This doesn't mean this is what happened, this is not why you're there. This is just what dispatch tells you and why they tell you you're going somewhere. So urgency. How often do we say that we responded emergent or non-emergent? Right, so priority 1, priority 2, that's what we're all using. We call priority 1 emergent, priority 2 non-emergent. Don't do that. For us, everything is emergent. So an emergent response is you're responding right now. So even our priority 2s, they get an emergent response. A non-emergent would be Joe gets a phone call today for discharge home next Monday. And that would be a non-emergent response. Our initial dispatch was pretty much now is when we're getting told about it and it's scheduled. So anything like your scheduled transfers are non-emergent. Any non-scheduled transfer, even to the retreat, is an emergent response because we're responding right now. For some reason, Medicare loves to use emergent and non-emergent as a reason to not pay us. Especially if we say we responded non-emergent for a chest pain transfer, or even a lady with a broken arm going to Dartmouth at the BLS level, we say it's non-emergent. Well, and Medicare says, well, that was actually emergent, we're not going to pay you. Pain in the butt. And then we have to get our signatures. So patient signs, both or all crew members sign, and then the receiving facility also signs. If you don't remember to get them, then you have to go back and hunt them down and find them. None of us want to do that. On transfer orders, we do need a physician signature on transfer orders with credentials. So they should have Jason Veith, comma, MD. And it needs to say your MD, DO, APRN, PA, RN, unit secretary, discharge planner, I don't care what it is, but they have to have credentials listed that gives them kind of the ability to arrange and certify that training. So our patient signature, they have to be physically and mentally able to sign. And just because they're ANO times 4 may mean they don't always are able to sign, even though they're oriented times 4. So they sign. In Siren, we should be putting up top patient name. Signature reason would be release for billing is the reason. And then last name, first name, hit the little clock and timestamp it. That's required. And then signed. Using that old yellow drop form, name gets printed at the top with the date and Rescue Inc. If you don't put that, Mark will kick it back to you. And then under their name, print their name, because that they can't read signatures, so they want to know who that person is. So just if you print their name under it, it's fine. If you put the date in, it's fine. But their signature is there, and that's in that first box. So the ability to sign. These are common reasons why patients can't sign. So they're unconscious, obviously. They can't sign for themselves. Their altered mental status. So their GCS would be 14. They're confused. Even if they're not coherent, and even if family says they're not acting right and they're acting a bit confused, or they might be oriented times 4. If they've got dementia, they've got frequent memory loss, then you can say that they're not able to physically sign. If they're in significant emotional distress, we can say that they're not able to sign due to emotional distress. They don't really know what they're signing. So if they can't really rationalize with you, just don't let them sign. Just have the nurse sign. And you can write emotional distress. If they're restrained, they're probably unable to sign because you have them tied down. Or as a result of chemicals, they are also unconscious. And then severe pain. So if it causes them significant pain to sign, you can use that as a reason because they probably don't want to move their arms. Multi-system traumas. If they're backboarded, it's not a reason to not have them sign, but I've had patients who will say, yeah, I can't sign my patient, my proxy has to sign. And that's fine, have their proxy sign in that second box down. And there's those patients that you're looking at them and the patient is saying, yeah, I can't move my arm up, like they have a CVA. They're post-stroke. They're physically unable to sign because they have neurological deficits. So those kind of things, always try to have them sign, but if they can't, don't make them, especially if they refuse. If they refuse to sign, then that's what we're going to talk about next. So they may have an adult family member sign. So these are your other alternate signatures. Is an adult family member, a home health aide, or the receiving facility. Receiving facility is your last option. If you can get like their caregiver, their guardian to sign for them, that's the better option. And then next would be like your home health aides. But any representative can sign. So the options in the kind of the bottom that we have here are, first one is patient's legal guardian. No brainer, of course they can sign. And that is not in the case of minors. So in the case of minors, the parent would actually sign in the top box as it's printed. So if you actually read that yellow form, it says if patient's a minor, parent or guardian signs up here. We're talking legal guardians for adult patients, patients who are kind of in the state system. They have a guardian attached to them because they can't make their own decisions. They're under the state care. Their guardian would sign in the second box down here if they're an adult. And you check that top box, legal guardian. The second one is a relative who claims insurance and makes claims for the patient and can kind of inherit their benefits and make medical decisions. The third one down is a relative who does not claim but still a relative. And then the last one is a representative of an agency who is not claiming insurance for the reason that payment is claimed. So that's literally anyone except our crew, anyone who's not rescuing, because we are representatives of the agency who's making claim. We're trying to claim that payment. So nursing facility staff, is what we're looking at there. So like you get a unit secretary sign, a nurse sign, and what they're signing here is that this patient is a representative of the facility that they were brought to for here. But they're signing that this is also a release for billing. So up here you would do signature status, either paper copy obtained if you got one of these yellow AOBs, not signed as to the reason why, and then you document your other signature as a representative signature. Most of us don't do that. We should try and get in the better habit of doing it. Transferred care, no access to obtain signature. So that would be you bring your patient direct to CT or in the trauma room at Dartmouth Hitchcock. Your patient physically can't sign because they're literally surrounded by 18 doctors. I try and get a signature before we get to Dartmouth. Probably your best option before you go in that trauma room. But generally speaking, the charge nurse there will sign for both, and they're used to doing that. But on your patient side, document a patient, not signature for the patient, for the reason transferred care, no access to obtain signature. That way it kind of covers you that, hey, I tried, but I couldn't. And as long as you document like effort, then you're fine. The patient refuses to sign. And this isn't, I can't, I physically can't, or I won't, this person has to sign for me. This is, I'm not signing that shit. I am not responsible for that. I am not going to release you to bill my insurance. Then we document, well, first we explain to them that they are responsible for the full bill. And without their signature, we cannot bill their insurance carrier. And we document that in the narrative. So under your transport section, I always document all signatures obtained, or what that situation was. If they don't, you document it there under your transport section that you were unable to obtain a signature, patient refused to sign, and all risks associated up to and including being responsible for the full bill of transport were discussed with the patient. And you put that right in your narrative. That way you're documenting it, you're covering your butt. It's like, hey, I tried, but I couldn't. The very rare occurrence is that there's no signature from the patient, and then the patient or representative or hospital staff are also not available to sign. This doesn't happen very often, but the crew member would complete this section. So typically on the very bottom, right under this line here, is where that nurse signs at the receiving facility. This is that box above there. This is that part A. So you document the circumstances as to why the patient can't sign. So they've got 10 on 10 abdominal pain, no representative or hospital staff available. Document the location and the time, and then you sign it, date it, and then print it with your credentials. And this is, if no one else is around, you can kind of do both. We shouldn't be doing this regularly, though. This is not kind of an acceptable thing to do all the time, but there are occurrences where it happens. So the receiving facility, we must have credentials. So again, we do hospital/receiving agent for a reason. We do a hospital receiving agent is the person. And it should be a last name, comma, RN. And then first name. And then date, time with that little clock. Signed, and they'd sign down here, and they put their little RN there. This is a big thing that I'm bad at, is putting the RN after their name. I haven't gotten any kickback because of that, but there's a potential to have them kick back. So we really should be putting RN there, and same thing down here. When they print their name, just have them put RN, MD, PA, whoever you have signed, just have them credentialize it that way. We know who's signing on behalf of that, signing for that acceptance. Just because you give a verbal report doesn't mean you can just leave. We need to leave paper documentation at every receiving facility, kind of as a summary of events. So if the EPCR isn't immediately available, we need to have one of these filled out, and the EPCR will never be fully available. It takes too long to fill out. So if you stay at that facility and write the entire electronic report and print it out, then that, no, we don't have printers. If we had printing capabilities, like at BMH, you get the entire EPCR done, you're fine because they've got Hospital Hub and they can access it. Same thing at Grace Cottage. You go to Cheshire, well, they can't tap into our system.
Oh, or Siren.
Yep, Cheshire can't get into Vermont Siren.
Unless something's changed, Grace Cottage doesn't have
You have access. You've always had access.
that. I've never been able to.
You've got to go up higher than you.
That guy's said that we don't.
You have access. I've talked to Elle and Andrew about it. You guys have access. It's probably a state thing.
I know.
It's probably a state thing at their end, honestly. You should have Siren access. Every Vermont hospital has access to Hospital Hub. I'm just not sure if it's probably not set up because it's Vermont EMS. So also at Grace Cottage, then in this case, just leave a paper report. It can be either this little orange half sheet, which is all right, or you can just use the drop form. I'll tell you what I do. I use the drop form on 911 calls, and I use the iPad tablet on transfers. The drop form's a bit easier to fill out. You can fill it out faster. It's all carbon copied. So you fill it out, you get your signatures, you give them the white copy, and you keep the yellow copy. Just make sure you use a ballpoint pen, not a gel pen, because it won't bleed through. Because it's carbon copy, it needs pressure. So if you're using a pen that you use very little pressure with, it's not going to carbon copy what you're writing on that front page all the way through. Been there, done that. So learn from my mistakes and use a pen that actually has a tip on it. You have to actually use some pressure. And then just leave that with. We should be documenting loaded mileage. And then if you go a different route than the commonly accepted route, for example, to get to the retreat, you go up exit 2 and then come down Cedar Street. You should document that detour because it's different than the common route. The mileage is more, and they want to know why. Whether it's because of a traffic delay, time of day, what have you, where your truck was located, just document it. On transfers, we have to have all sections filled out. So patient label goes up here, date and time. Have someone at the facility fill it out. The unit secretary should be double checking it. The patient's nurse should be further double checking it, and then you should be the last verification to make sure this is filled out. But we still get these filled out that are incorrect and missing information, no matter how hard we try. The unit secretaries are busy and they just don't look at everything. The nurses don't exactly know what they're looking at, and the physicians want them out of there. So this is one of those things that don't be afraid to tell them to correct it. It's not your problem, it's the hospital's problem. You should give it to the unit secretary, give it to the nurse, give it back to the doc. Ultimately, the doctor has to fix it. But no cross-outs are allowed. That's the thing. We can't cross stuff out. They can add to an initial after the initial form is filled out. So you can bring this form back to the doctor and say, yeah, I need this reason filled out here. And they can fill that out. But you can't cross out, say, EMT and circle paramedic. You could circle paramedic and make a note saying transfer actually at paramedic level. So that would be appropriate. And then origin, destination, room, which we don't usually know half the time. We know what unit usually, but we don't usually have they've got a bed assignment, but no, they almost never tell the receiving facility what bed they're going to. And then the receiving MD. Try and get it all filled out the best you can. The worst that happens is we don't get paid, and now it's an invalid transfer. So risk. Make sure that this matches your level of care. If there's any risk for deterioration, it should be a paramedic level transfer. If they're stable, then EMT, AEMT, all the way. If there's risk, an EMT shouldn't be taking it. If there's risk of deterioration, AEMT shouldn't be taking it. I've seen this before where I've looked at the order set and it says risk for deterioration. The only case where it would be acceptable is you're bringing a hospice patient back home, because there's absolute risk that they're going to die en route, but they're going home for the purposes of dying. That's probably one of the only cases where it's acceptable for an EMT to take a patient who has risk for deterioration. And then this flag here, that's for any abnormal vital signs or lab findings. If that's checked, read it and understand it. They may be stable, but there may be a critical flag on there. And if there's a critical flag, run it by the supervisor if you don't know what it means, especially if you're not comfortable taking it. We did a PIFT class recently, and the reality is if you're not comfortable taking this transfer, don't take it. You have every right to refuse to take any transfer that is above your comfort level and above your scope of practice. So we've got two A's in the room. Keegan, you may be pretty comfortable with everything in the A scope. Jamez, you may not be. Just because it's A level doesn't mean that you're both held to the same standard. In theory, you should be, but if Keegan's comfortable and Jamez you're not, you should be speaking up, Jamez, and saying, yeah, I'm not really comfortable with this transfer. I've got these concerns about it, and make those known. And you're absolutely encouraged to refuse transfers that have risk of deterioration that you're not comfortable with. The supervisor should back you up, and if they don't, just go a step higher, go to the captains. And if they're not backing you up, go a step higher. This is for patient safety and your protection. Protects you and the patient. So next we're going down to the reason. So is it for discharge? Are they being discharged home? Are they being discharged to a nursing facility? That would also be a discharge. And then are they going for diagnostic imaging? Cheshire does a lot of ultrasounds that Brattleboro doesn't do. We go to Cheshire a lot for these transvaginal ultrasounds or for T procedures, transesophageal echocardiograms. Cheshire does them, BMH always doesn't. Cheshire can bring an ultrasound tech in, they can do it over there, and the patient will come back to BMH. So patients go to Cheshire a lot for these. And then they come back. Is there a psychological crisis? So risk to self or others, homicidal ideations. Make sure those are checked. And what's the reason? Always has to be a reason for transfer. And that reason should match the physician's note. So we're going to have new guidance coming out in the next few weeks on physician's notes, because we've been giving out kind of free transfers because the physician's notes aren't accurate. And it's probably not because they're lazy, it's probably just because they don't know. But our reason for transfer, higher level of care is not appropriate. It has to actually be an actual reason. And this last one here is required services, specialized services, not available at the sending facility. Thompson House has specialized services that are not available at BMH. Long-term nursing care is not a service that BMH provides. They don't provide that level of environment. So a patient going to a nursing home is absolutely going for a level of care that is not provided by the sending facility. Next is our medical necessity. We need to have boxes checked off here. Reason. And then on the back of the form is all the drugs. Just make yourself familiar with those, because you may be seeing that more and more often is a box is just checked. And that's fine. Let's say, so glucose is checked or oxygen is checked. That's all you need. Because on the back of that form, it'll say oxygen, 2 to 15 liters per minute. Or in your case, it'll say crystalloids, 100 to 1,000 milliliters per hour. You get the whole range. So by the physician checking that box, they get that entire dosing range. If they want to modify it, they can. But up front, we're saying these are our ranges. If you want to adjust it, you can. If you don't want to adjust it, just leave it as it is. and you get an automatic range. What we were seeing was that physicians in the bottom here would write oxygen, or they'd write normal saline, and you'd be like, well, what rate do I run this at? I don't have an order. So by actually putting the orders, giving the ranges on the back of that form, the range is implied. We have the whole range. So what you guys might see would be like D10. Would be one that have something like that. At the bottom, signature with credentials, time, date, print name, and we have to have this phone number. We have to have that proxy phone number. If there's no proxy phone number, this is to save your butt. So you're going over to BMH, Dr. Swosey is taking care of a patient. He is there when you leave. Well, now it's been 10, 15 minutes and they've had physician changeover. You've got Jason Veith now there. This patient was transferred out. Jim didn't give him report on your patient, and now you're calling for orders. He knows nothing about that patient. So there has to be a phone number and a proxy there for you to call if changes arise. Jim's going to be signing out that patient to Veith just like he was still admitted in the ER. So that way you can call for orders and get orders if you need it. That way they're aware of it. So MedNec, so this reason. And some examples that we're losing to Medicare and Medicaid are they pay these people bottom dollar. And they look at a list and they say hospitals can do this. And surgery is on that list. Well, we all know that Grace Cottage can't do surgery and will never do surgery. They don't have an OR suite. They don't have OR staff. They're never going to do surgery. But so transferring a patient from Grace Cottage to BMH for orthopedic is completely appropriate in our minds. But if we don't document and the physician doesn't document in their report that the patient is being transferred for orthopedic services not available at this facility, then it's an invalid transfer. They're kind of freebies. So it needs to be documented. It's not the patient isn't being transferred from Grace Cottage to BMH for personal preference. They're being transferred because, and granted, the patient may have preferred BMH over Dartmouth or Cheshire or Bay State. But the reason isn't patient preference. It's that Grace Cottage can't do surgery. It's not a service that's available there. And this is coming up a lot. So just double check the physician's note. Double check the order set. Write it in your narrative that patient's being transferred for surgical services not available at sending facility. Because like we're looking at like you pull some Joe Schmo off the street, say here's a list of what hospitals can do. If it's not on this list, it's invalid, and that's really who you're getting. That's who is reading our reports. People that really don't know the area. So we're trying to make it common denominator, firefighter proof, and understandable. Then why it's occurring. And we already talked about that a little bit, but specialty facilities, inpatient psych services, long-term care, and then bed confinement. This is new to a degree. It used to say or. And now it says and. So they're unable to get up from bed without assistance, and they're unable to ambulate, and they're unable to sit in a chair or wheelchair. So if your patient's doing a O2 test, and they're walking down the hallway unassisted, patient's not bed confined per definition of the government. So if we're looking at this patient, and this is actually fraud if this patient goes by ambulance and they're saying they're bed confined but they're not. That's fraud. And a lot of places try and do this without really knowing what the law is. Like they don't know. It's not their fault. So we need to give them a little bit of education as to what bed confinement is. And then there's how you found this person. What is that?
Sitting.
That's a chair. What is that? That's not sitting. That's a medical recliner or a dialysis chair. So it's not quite sitting, it's reclining. Kind of. What's that? That's a wheelchair. It's different. And then what's that? That's a bed. Some people are saying that this is sitting. This is not sitting. The real difference here is our knees are bent at a 90-degree angle. Is sitting. Reclining is between 90 and flat is reclining. And then legs flat is semi-Fowlers or Fowlers or supine. These are your positional terms. So back in EMT school, we learned all these terms. We're like, that's a bunch of horse crap, and we don't really need to know that. When it comes to billing, they actually do care about all those medical terms of patient positioning. So document how you found them. Because if they're saying they're bed confined and you find them laying like this or in a medical recliner, yeah, they could be considered bed confined. If you find them in a wheelchair or a chair, they're not bed confined. So these are a lot of reasons of patients who are maybe considered bed confined. I won't go over all of them, but if they've got like truncal atresia or vertigo, they may consider that bed confined because they can't get out of bed without assistance. They try and get up and they get dizzy and fall back down. And once they get vertical, they fall down because they've got vertigo. So they would meet the definition of bed confined. It's not always because they are too weak. It may be for other reasons that they can't get out of bed on their own and they can't ambulate. If they're being transferred for wound care, for some reason the government wants to know this, document the stage of the wound. They want to know what stage that decubitus ulcer is. Not sure why, but they really want to know.
Are we staging the wound itself, or how would we?
Physician's note. Yeah, we're not trained to stage wounds. I wouldn't even know where to start, honestly. Ask the nurse and document what they tell you, or look in the physician's note. On the topic of physician's notes, if you can, ask for a second printout, second copy. We've asked the facilities to start doing this for all interfacility work. Some of them might get it, some of them might not, but get a copy of all the physician's notes associated with today's care, and it may incorporate 2 different physician's notes if they signed out once. Get that note and scan that note in to your report. Because by not having access to that note, what we're looking at is if they're being transferred for a reason, and that reason isn't well documented in the physician's note, we don't get paid for it. It's kind of like this transport here. Go ahead and read that real quick, and let me know what the reason they're being transferred is.
Why they're being discharged?
Yeah, why they're being transferred by ambulance.
Back to Pine Heights?
Yep, why are they going by ambulance? And I don't even know where this report came from. It's one of Ellen's that she pulled.
There's no reason.
Correct. So one, there's no reason over here, but they've checked the box for medical supervision, and there's no positioning, there's no how they were found, they're going back for long-term nursing care not available at BMH.
They'd say they were found supine in bed.
Right. Are they bed confined?
No.
Do they have a stroke history? Is that why they're going back to Pine Heights? We don't know. We can't bill for this. This is a free transfer. And this is a relatively comprehensive assessment. It's a decent history, but it's missing the few key points that make it billable. We don't know what they're supervising and why they couldn't travel by other means. For transferring of minors, have a signed consent by a parent or guardian acquired by the sending facility. We don't need a specific form. They get read on a napkin for all I care, or a half piece of 8.5 by 11 paper. But all it has to really say is, I, so-and-so, give permission for Rescue Inc. to transport my son, daughter, etc., or the person's name, to transport so-and-so to location, period. Sign it, date it. And they should put their relation in there. I, mother of, whatever, father of, guardian of. That's all we need. Napkin for all I care. It just has to be that parent giving consent and have it written. The yellow forms at BMH give BMH permission to treat and transfer. But it doesn't give us to have that consent to have that person in the back of our truck. So we need to get consent as well to cover ourselves legally.
So
We explored this. Yeah.
You're saying there's not a specific form for this. Is this just having them sign, like what a patient would normally sign?
No, we have to have written, documented consent.
We don't have forms made up for
There's
that?
no, we don't want a form for it
We
because
just get a blank piece of paper and have them write on it?
because the reality is that mom may be out in California. We can't fax her a form. We can't email her a form. What she could do is she could email us and just type up, I give Rescue Inc. consent to transfer my daughter, Jane Smith, to the retreat.
So we should be getting that ourselves, or we're going to be getting that from
That should be above you. The hospital should be getting that consent for us,
Okay.
but it should be initiated by the supervisor here. And when you go to take that transfer, someone should give you, you should ask the supervisor if it's a minor, do you have consent or is that a BMH?
Okay.
And then you'll either get a consent form here, if it's coming by email or text.
Mm.
Heck, I imagine they would take a text too.
Yeah.
Take a text, take a screenshot of it, take a screenshot of that consent, and attach it to the report.
Okay.
So it's in addition to them signing on the. How much longer you got?
Not much.
I need my partner.
Uh-huh.
You sign her off, I take her now.
No.
Send them up and we can go up and relieve them shortly.
I don't know what the fuck's happening.
No idea. But the reality is that, yeah, so like either we can get consent by text, email, it's just to get it. That's all it is. That's why we don't want to have a form.
That's in addition to them signing on the.
Yes, so signing the AOB on the iPad is just release for billing.
Okay.
That's a common misconception that we've talked about over the years is, this is because I brought you here. Like this is saying that I brought you here to BMH. No, it's not. We've been lying to them for years. What it really is that they're releasing us to bill their insurance.
I would say it's a release for insurance, release for billing, and permission for us to have brought you here.
It's not even permission to bring you
The last
here.
part's probably not true.
No, it's not. It is purely released to bill their
I
insurance.
just do it so it sounds better than here. Please sign this so we can charge our insurance company money.
Yeah, but that's really all we're doing. That's all it's for. That's all that line is for, is to bill them.
What if they don't have insurance? What's the signature doing?
That they're responsible for the whole bill.
Okay.
Yeah, they're saying I'm responsible for this bill. I'm responsible for the part not covered by insurance, and I release Rescue Inc. to bill my insurance. So what to include? Dispatch, chief complaint, history, assessment, treatment, procedures, and transport. DHART, we're all familiar with it. So dispatch, priority 1, priority 2. What you were dispatched for, who else is going with you, and there's any updates en route to the scene. Put this on your dispatch section. Chief complaint. Include reasons why the sending facility is incapable of providing care in your chief complaint. This is kind of the situation surrounding this transfer. If your patient doesn't state anything, state your primary impression. So unconscious, difficulty breathing, overdose. We've all seen those patients that have so tachypnic and they can't breathe that, hey, why are we here? All right, none offered. You're too hard breathing. You're not going to tell me anything. I know what's wrong. But their chief complaint is difficulty breathing because you can visualize it. For IFT, the chief complaint, state the reason or diagnosis requiring the transfer. Why are they going? Is it for cardiac catheterization? Is it for surgical of their forearm that they snapped in half trying to ski? What is it? History. What are the events leading up to? And is there any pertinent history as well? Don't include all of it, just the stuff that's applying to today. Any pertinent scene observations, and then any patient-stated information regarding the incident. So why they need an ambulance, why other means are contraindicated, and why it is unsafe to go by other means. This is kind of your story about why you were called. Next we get into our assessment, and this is the kind of the meat and potatoes of your report is your assessment. The better you assess, the better you actually treat your patients and do assessments. So I do a brief primary impression up top, and you don't have to use my template. Find something that's similar. And then I qualify their history ability. I qualify what they're telling me. So their orientation, their mental status, and are they a qualifying self-historian? That's where I start. Then I go into mental capacity, and I include that in my neurological assessment. So diagnosis of dementia, but they appeared alert and oriented. Family states they have occasional episodes of confusion. At BMH, they may not be a reliable historian, but for you they are. That's how you qualify that. Discuss pertinent negatives. So dyspnea with clear lung sounds, chest pain without dyspnea. This further paints the picture of what's going on. And then HEENT, head, eyes, ears, nose, and throat. So pupils, gross visual acuity, really, can they see? Not even what is this, but more like, is that a poster, or what shape is that thing on the wall over there? It's a square. Do they have any visual acuity, and are they not blind? Is the airway patent, secured, obstructed, or compromised? And you can use those three terms if you want. I like them. Airway's patent means they're breathing on their own. Secured means you have an advanced airway in, or compromised would mean it's full of secretions. It's not there because they don't have an airway. Those are kind of the general terms that you can use to describe an airway. Skin, so color, temperature, condition, turgor, diaphoresis. What else is there? Chest, is it stable? Is there equal rise and fall? Do they have lung sounds? What do they sound like? And you can do your cardiovascular assessment here as well. So under cardiovascular, you want to talk about pulse quality, strength, heart tones, auto-interpretation of the ECG, if you have it, end tidal, waveform, what that looked like. Abdominal, so distension, rigidity, tenderness, pain, radiation, or bruising. So you can discuss those factors as well. GI-GU, so presence or absence of incontinence, especially when we're talking about seizures or the elderly patients. Is there a Foley catheter in place? And then priapism, eviscerations, nausea, vomiting, and describe it. Was it coffee ground emesis? Was it frank blood? Because that kind of further paints the picture of what's going on. Discuss the back when it comes to deformities and pain. And is the back pain pre-existing or acute? And then we can talk about the pelvis. Is it stable? Is there pain or discomfort? How are the extremities? Any deformities, pain, or alterations to CMS? And after that, I do a working diagnosis or a field treatment plan. I do this in the bottom of my assessment. I call it clinical decision making. Todd calls it concerns. But by sticking it in your assessment, it's basically taking your entire head-to-toe assessment and boiling it into what you think's going on, what you're treating. And this kind of quantifies why your treatments are what they were. So you can do like assessment findings indicate weakness times 3 days. We're going to rule out pneumonia. So that would be why they need an ambulance and why you're going down that treatment pathway. Treatment, so list them all out, including assessment. Your cardiac monitoring, including 12-lead ECG acquisition, that is a procedure. And all your procedures should also be documented under procedures in the procedures tab. So in a way, we're double documenting to a certain degree. But there are things that we do that aren't listed as procedures because Siren sucks. Same thing was with patient history and patient medications. There's stuff that we document in our narrative that just doesn't exist in the drop downs, and the most frequent option we want to choose is no other appropriate choice. So this may appear narrative style as well. So if you do a treatment and they improve, I'll generally write the treatment. So we administered 25 grams of oral glucose. Patient resumed a improving mental status. So you can document that in there. That almost goes narrative style, but it shows that your treatments had an effect. So document your treatment effects if it had an effect. How you got them out of there. How you secured them in the ambulance. If not the stretcher, explain why. So captain's chair or bench seat. You had multiple patients. Patient absolutely vehemently opposed to stretcher, refused to sit on the stretcher, but were unable to be transported by other means for medical reasons. Patient was amenable to sitting on the captain's chair, secured the captain's chair and seat buckled in. Some psychiatric patients, they will not sit on the stretcher. And sometimes the only way to convince someone to go, if they need to go, is to have them sit in the captain's chair. Do it. It's our last-ditch effort to get them to go, but if they need to go by ambulance, we can find a way to make their needs met. And then how we secured them. Transport, so destination, any changes or actions taken, how we transfer the patient to the bed or chair or wheelchair, the nurse name who assumed care, and anything that changed en route. So, for example, here we transported to BMH room number 10. They attempted elopement en route, and restraints were applied for patient safety with notification of medical control. They were unable to refuse care due to altered mental status and significant head injury. We transferred to the ED stretcher via sheet transfer, and restraints were maintained by the facility staff. Report given to RN Dan Drish at bedside, and care transferred without incident. So that kind of meets all this criteria, and it factors in that there was a change en route and how you handled that. Choose your own destiny, also known as DHART style. Templates can be used. However, you shouldn't be copying others' templates. So don't use my template. Don't use Mark's template. Make your own. Learn it, live it, love it. They do help with consistency, and they make sure that you include everything required every single time. Again, the better you document, the better you actually assess your patients because you're thinking about documenting it. Find your style. Find your verbiage. Don't copy someone else's template and exact verbiage. Make it your own. The billing company sees repeat templates it's the exact same from different people, and now they're looking at fraud. They're thinking that someone is actually writing other reports that's not really yours, and that's illegal. So, DART landing, get the crew signature, get the patient signature. You're not the primary provider, you're secondary provider. See the handout? So there's no transfer orders, just the face sheet and the PCR if you did it not on the iPad. All treatments should be performed by the DART crew. We can list how we assisted though, as requested by the DART crew. So this is that narrative. So dispatch, chief complaint, This is a pretty involved one. You don't have to put this much information in there, but this report should be pretty quick. There is a handout upstairs on the bulletin board. Just copy that verbatim. And then 2 EMS signatures. The DHART crew member is your receiving agent, and then the patient signature reason. And this kind of format was vetted by billing, and they're completely okay with it. This is what they want us to be using. Questions, thoughts, concerns, recommendations? We find out new stuff every day about what they want. We're trying to keep on top of it and keep you guys all updated. Sometimes it may take a little while to get the information out, but we're trying hard to get this stuff more solidified and increase communication.